Okay, guys. Finals review for my portion is hopefully going to be short and sweet. And without further ado, let's get started. It's been one of those days. Have y'all had one of those days? All right, final exam review. Everybody knows this is a 100-point question. It's divided up between uh, a bunch of us. So we are just, each one of us are going to take our portion and go over it and make sure that you understand what you're going to be studying. So let's just see if we can get on with this. Okay, the ones from high risk OB. We talked about pre-eclampsia. We talked about a whole lot of things. This was the one that had the 13 chapters. And to ask you to go back and study those 13 chapters would be a little bit much. Although I'm sure I would love for y'all to be able to know all that good stuff about it. So, first of all, concentrate on preeclampsia. What is preeclampsia? Preeclampsia is where your blood pressure is greater than 140/90, where they have more than +2 edema, where they are spilling protein in their urine. So they have proteinuria, they have edema, and they have hypertension. And this usually occurs after they're 26 weeks pregnant. If it occurs before then, it's usually considered pre-hypertension. So we're just concentrating on preeclampsia. So how do we treat preeclampsia? Preeclampsia, bed rest is one of the ways we treat it. We may or may not go down on their sodium. We are not treating preeclampsia when we treat with medications. The mag sulfate that we give is for seizures that may result from preeclampsia becoming eclampsia. So we want to prevent that. Hypertension that results from preeclampsia, we want to treat that with pregabalin. Those are the two drugs that we use. Other than that, we do bed rest, we keep the room dark, we do seizure precautions, and try to get the patient to a point where they're delivered. And once they deliver, they're usually have no problems with this. But my experience has been that some of them continue to go on and continue with hypertension. So there's may have been an underlying hypertensive disorder all along the way. But some of your signs and symptoms of your patient that comes in with preeclampsia, what you're going to be looking at what with the three that we just talked about. If you have a patient that calls you on the phone and they complain about a severe headache, you want to tell them to come in. Severe headaches are maybe intending of developing on into the HELP syndrome. So, if you have a patient that's presenting in with preeclampsia, some of the things that we watch for, um, especially with the seizure precautions, is we want to do those deep tendon reflexes. So when you have a patient that comes in presenting with some what you think may be a severe case of preeclampsia, you always want to make sure that you're assessing those deep tendon reflexes, because that can tell you whether or not your preeclampsia is going to go ahead and develop into eclampsia. And that's very important. It would probably precede any of your other assessments that you're going to be doing, except for fetal heart tones. So those are things you want to watch for. Abruptio versus placenta previa. Remember my PowerPoint that the slide I gave you that had the abruptio on one side and placenta previa on the other one. Abruptio may or may not present with bleeding, and it's usually dark red. Placenta previa will present with bleeding, always vaginal bleeding, and it will be bright red. Abruptio will be very painful. The abdomen will be rigid and tender, whereas the placenta previa, she won't be feeling any pain at all, because the bleeding comes from the placenta tearing loose from the cervix, or pressure the baby onto the cervix, and there's not that much pain. Whereas with the abruptio, the bleeding of the placenta tearing away from the uterine wall is very painful, and the more blood that gets in behind there, the more pressure, the more pain. So those are some of the big differences. Of course, fetal monitor strip, you would see some difference there as well. So you would see with abruptio, you would see some distinct fetal distress. Placenta previa, you may be seeing a sinusoidal pattern if there's been a lot of blood loss through the placenta previa, but usually with placenta previa you don't see as much fetal stress as you do with the abruptio, because with an abruptio the fetus can be dead within minutes, seconds from the, it depends on if it's a complete abruption or an incomplete abruption. Okay, gestational diabetes. You know, gestational diabetes usually develops after 24 weeks pregnancy. If they are having problems with their glucose before then, they are pre-diabetic. So gestational usually develops around 24 weeks when the placenta becomes insulin resistant, or actually produces a hormone that is insulinase, that is insulin resistant. So you're going to see mom having some higher glucose levels. Usually what we do to treat gestational diabetes is we start out trying to control the gestational diabetes with diet and exercise. According to some of your guidelines, about 80 to 90% of gestational diabetics can be controlled with diet and exercise alone. Uh, the further into their pregnancy they get, if they get so far into their pregnancy and they are no longer having control, then they will go to insulin. But our first line of defense is to do the most conservative treatment we can do, and then advance to the other. So the very first thing we're going to do with our gestationals is do diet and exercise. Then we will eventually, just like with any other disease process, it's type 2 diabetic, you know, if they can't control it that way, we will continue on to bigger and better things to give them. Our babies, we've talked about babies of gestational diabetics versus type 1 and type 2. Your type 1, remember, definitely needs, and your type 2, they need to have strict blood control, glucose control in their, or before they become pregnant, because the deformities that can occur with these babies of mamas that are insulin dependent, type 1 and 2, will occur in those first few weeks of development. In that first 8 to 12 weeks of development, where all your systems are developing, your cardiac defects, all those defects will occur in an insulin dependent diabetic that doesn't have good glucose control. Your gestational diabetics, on the other hand, they don't become diabetic until after 24 weeks. So all of that, the organs and everything have already developed. So the most of the things you worry about with gestational diabetic babies are that they're very large babies. They're macrosomial. Their heads and shoulders are big. They're just little fat, puffy babies, and they are at risk for fetal death, just as like the type 1 and type 2. But the biggest thing we worry about them is that they are macrosomial, may be difficulty having delivery of them. When they're born, their LS ratio that indicates lung maturity may not be quite as good as it would be with a baby that's not, because their lungs don't mature well. So we worry about respiratory, and we worry about hypoglycemia. So those are three of the things we worry about: macrosomia, hypoglycemia, and respiratory problems. Okay. Now, when we have a preterm infant, remember, when preterms, they are undeveloped every which way but loose, right? Preterm infants, they need respiratory support, they need nutritional support, they need a thermal support. They can't do anything on their own like like the term babies can. They can't produce their own heat, they can't do any of those things. So basically, a preterm infant, the minute they're born, one of the most important things that we're concerned about is, are they breathing? You know, airway's always first, even with preterm infants. If they're not breathing, we need to do bag and mask, positive pressure to get them breathing. If, you know, of course, we do the stimulation thing first, but when we have a preterm, we're pretty sure their lungs are immature and they're going to need some oxygen support, some respiratory support. So if they're not breathing after stimulation, they're going to need to be bag and mask, and they're going to need oxygen support. Um, and they may even end up with intubation depending on how preterm they are. Substance abuse, funny thing about this one, withdrawal abstinence syndrome. I just came out of the Kaplan Live review here on campus, and the question was about abstinence syndrome. What will you check first? How do you manage to answer the question? So I'm thinking about not even telling you anything about this. It's probably you should get this one. But then there are some of you that are taking the online review, and I wouldn't want you to feel left out. So you all remember what neonatal abstinence syndrome is, when the mother has been dependent on drugs and the baby therefore is dependent on drugs, and when they're born, or when if you give them Narcan, anything that takes away their drug of choice or mom's drug of choice, they have certain symptoms that we watch for. And they're usually very irritable babies. They are very hard to please. They cry a lot. Their cry is persistently shrill. It hurts your ears to listen to it. Very shrill cry. They have hyperphagia. They are hungry all the time. They want to suck and eat because their body's telling them there's something I need. And the only thing they know to do to meet that need is to suck and try to get comfort from that. So they just want to constantly eat because they're trying to meet that with a need for that drug that they have. A lot of them are hyperreflexia. They're very rigid. They don't relax. Best thing you can do for them is to wrap them up in a swaddling blanket and wrap them up tightly so that their jerking movements don't startle them, and it gives them a little bit of comfort of feeling like they've been in the uterus. So those are some things that you need to be sure that you're watching for with substance abuse. These babies can die. Methadone is preferred to use with the mother who's on heroin addiction. And then when the baby's born, the baby will have to be put on methadone and gradually weaned off. But be sure that you know the symptoms of abstinence syndrome. And that was all of the prenatal, or all of the high-risk OB. That was just a little bit out of a whole lot, wasn't it? Okay, Kawasaki disease. This came out of your cardiovascular pediatric, and some of the things that we really want to be sure that we are that we know about the Kawasaki disease is that hmm I'll come back to that one because I think I wrote that question down wrong. So I'm going to look that up before I tell you any answers on that. They just don't look quite right to me. Okay, so let's talk about fetal circulation. What are the structures of fetal circulation that are not supposed to be in pulmonary circulation? Fetal circulation involves the foramen ovale and the ductus arteriosus. Those are the two structures that without them we would not be able to have fetal life, because the blood from the placenta would not be able to circulate. It circulates through the foramen ovale from one side of the heart to the other, and then with the patent duct, with your ductus arteriosus, it will allow, because of the pressure gradients, and I'm not going to go through all the pressure gradients with you, but because of the pressure gradients, the pressure of the fetal lungs is a lot higher than the systemic pressure. It allows more blood to go through the systemic system through that ductus instead of going into the lungs. And that's one of the important things of the fetal circulation structures that they have that they need to do. You need to know your increased blood flow, your decreased blood flow, mixed blood flow, and obstruction of blood flow. Know how they work. Know which ones are which, like the increased blood flow is your PDA, your ADA. Those are some defects that you're going to have the left to right shunt. With the left to right shunt, your babies are acyanotic. So the increased pulmonary blood flow is acyanotic, and it results in more oxygenated blood going back into the pulmonary system. So that's a defect that will eventually cause congestive heart failure. But at birth, this is what keeps them alive, is that they have some of the defects with having some of the babies. Now, that baby, your preterm baby, the babies that need to have some extra blood flow and don't need that to flow. So there's some portions that we need to know about that. Coarctation of the aorta is one of your obstructive blood flows because your aorta is obstructed. One of the best ways we can, if we suspect that our patient has coarctation of the aorta, we'll do blood pressures in all four extremities. The lower extremities should have a lot lower blood pressure than the upper extremities because the aorta being constricted, the blood will not be able to flow into the aorta through the rest of the body. Instead, it will be limited to the upper portion of the body. So you want to be sure that you're checking your blood pressures and how you would determine that with the obstruction of blood flow, which coarctation is one of those of the blood flows. So one of your mixed blood defects is your hypoplastic left heart. It has several defects in it. It has the pulmonic stenosis. It has hypoplastic left ventricle. It has a hypoplastic ascending aorta. The thing that it also has a patent ductus arteriosus as part of this defect of mixed blood flow. So we have blood that flows deoxygenated into oxygenated, and we have oxygenated going into deoxygenated. Without that patent ductus arteriosus, these babies would not be able to survive for any length of time. There would not be enough mix of the blood flow to be able to meet the oxygen needs, and the oxygen needs will be very low. The baby cannot be very active. Any activities will cause cyanosis and will cause the crying can cause the ductus to be stimulated to close. So the ductus really has to remain open for our hypoplastic left heart that has a mixed blood flow. So that mixed blood flow is what keeps that baby alive. Then we have the so we did the obstruction. So decreased blood flow. We haven't done the decreased blood flow. Your decreased blood flow would probably be something with tetralogy of Fallot. Tetralogy of Fallot is one of your decreased blood flow. It has four defects. It has that ventricle septal defect, but also has pulmonic stenosis, overriding aorta, and right ventricular hypertrophy. So if anything upsets the balance here, they have terrible cyanotic spells, known as TET spells, which is next on our list. So with tetralogy of Fallot, they will turn blue, and it's difficult for them to breathe at times if they get stimulated. So we often teach the parents to put these babies, when they are beginning to have one of these hypercyanotic spells or TET spells, in a knee chest position. And the knee chest position is like just holding them in a fetal position up on your chest, and that will decrease the blood flow to the lower extremities and increase it to the upper extremities. So that is how the knee chest position works to help relieve some of the acyanosis and hypoxia. Also, with these TET spells, there are certain things that will trigger TET spells, and it would be anything that would cause them to have any kind of stress. So, be things like feeding, infants that have to feed and they get overstimulated with feeding, get overly tired, even having a bowel movement, and especially crying, are some of the things that will actually cause TET spells to become very apparent and will actually trigger them. Congestive heart failure, you need to know about congestive heart failure. Um, One of the things basically I want you to know about congestive heart failure is how do we treat it? What are some of the things we do for it? We know that a lot of these cardiac defects can lead to congestive heart failure, and that's basically what happens. They have a cardiac defect. It leads to, if the defects are not fixed, then they can go into congestive heart failure. The signs of congestive heart failure: restlessness, shortness of breath, and basically they get edema. And usually we treat that with digoxin, and we treat it with diuretics. Digoxin, we have to watch their levels, make sure they're not getting dig toxic. And that's how we know whether our dig is working or not, is if our cardiac output is increased and if our heart rate is a good, strong, slow heart rate. You have good contractility of the heart. With our diuretics, such as Lasix, we know that that works mainly from the baby having a good output. And when they have a good output, the way that we know that they are actually losing that excess edema is if they have weight loss. That's one of the reasons why we do daily weights on babies. You know, we have a good input, we have a good output. Daily weight is what's going to tell us if our diuretics are working correctly. So be sure that you remember that. I don't know how many times I have said that through adults, peds, babies. Anytime you give a diuretic, the way you teach your patients when they go home. Weigh yourself every day. So, you know, if you start gaining weight, you'll know that your diuretic is not working. Unless, of course, you're like me and you eat like a pig and you gain lots of weight. So, the one thing I wanted to look at was the Kawasaki disease. And I'm pretty sure that some of the things that we really don't know what causes the Kawasaki disease to start. It's a type of vasculitis. Um, and there's several different stages for this. They usually have to have the aspirin, and they have to have the immune globulin that they take, or the IVGG, gamma globulin. So be sure that you realize, that this is one of the diseases that we actually have to do aspirin for, although, we have always been very cautious about giving aspirin to any child that's running a fever, any baby that's running a fever. Want to be sure that we are continuing with that. These children are very irritable, and that is one of your major hallmarks of Kawasaki disease. So irritability of the Kawasaki disease is one of your major markers telling you that they have the Kawasaki disease. They'll have those erythema on the palms and the soles of their feet. So, and then of course we have rheumatoid. We have rheumatic fever, and our rheumatic fever is usually caused from a previous staph infection or strep infection, excuse me. When a patient or a child has strep throat and they're not treated for strep throat, then this will trigger an immune response um, where it sets up an inflammatory response in the mitral valves. And it is not contagious. You remember that we talked about it is not contagious. And so it's okay for them to have contact with others. We want to be sure that we are treating their symptoms. And of course, this is another one where we have penicillin given and we do aspirin. So, and of course, my phone's going to ring right about now. And let it go to voicemail, I hope. So rheumatic fever also has polyarthritis. Remember we talked about that, and that's what we give the aspirin for, is the polyarthritis. So they may continue on their aspirin treatment long after some of the other symptoms are gone. Once you have rheumatic fever, it's always important to follow up with strep, and so we need to make sure that strep screens are being done. And then we get into the stages of syphilis. Y'all know the 4 stages of syphilis. There's the primary, the secondary, the latent, and the tertiary. So look at those and be sure you know which one is which. I'm not going to sit here and go through there. TURPS, that transurethral removal of the prostate, is usually done for sorry, I got sidetracked on reading something else. It's usually done for prostate cancer. It's usually not done for just an enlarged prostate unless it's just severely enlarged. So what you need to know is, when they have this transurethral resection, we talked a lot about recovery, what you should do when they come back from recovery. Be sure they don't have bright red bleeding in their catheter. Be sure you're doing irrigation for bladder spasms. And then you have discharge teaching you need to do. And a lot of times, nurses forget to tell our patients that they may have some dribbling for 3 months or more after having this surgery. It takes a little while for them to get that control back, and they think that they are going to, everybody thinks that when they have incontinence, especially guys, they think that that's the end of their life. So we want to be sure and let them know that they have, that can be persistent for several months, and it's not a sign that anything is wrong. It's just a process of healing through that. BPH, the symptoms of BPH is the frequency, difficulty starting their urine, unable to empty out their bladder, several things that the enlarged prostate will cause as it presses up against the urethra. And the medication that they usually give someone with BPH is Flomax or some particular type of in that drug category. And all of these, the way these alpha receptors work, or blocks, the alpha blockers, the way they work is that they block that receptor in the peripheral arterial system. And of course, when that happens, you have orthostatic hypotension and dizziness. So remember, usually we tell everybody that takes Flomax or any type of drug to help them urinate better is to be sure and avoid sudden changes. Be sure that you don't, if you get dizzy, to please sit back down and such. Menopause, we didn't get to talk a whole lot about menopause because your book didn't really go into a lot about menopause. It talked about PMS, it talked about other things, but it really wasn't into menopause very much. One of the big things in menopause, and this is after a woman has gone over a year without having a period, then they're considered being in menopause. And then one of the things that most women suffer through are hot flashes and vaginal dryness, severe vaginal dryness, and painful intercourse. And so the main thing the only thing that really treats that or targets that is your hormone replacement therapy. And hormone replacement therapy has been controversial for the last 20 years I've been teaching this. And some years it's highly recommended, some years it's bad for you. So, the things I need you to know about hormonal replacement therapy is that only if you have severe menopausal symptoms, really severe hot flashes, severe mood swings, severe painful intercourse, these are things that you should take hormonal replacement therapy for. You should take it only for as long as you need it, and hopefully after a certain time that you're actually will get through the hot flashes and the mood swings. But hormonal therapy does help women protect them from osteoporosis, but it also increases the risk for breast cancer. So they really should be doing self breast exams as well when they're on HRT. So our urinary health. When a patient has been coming in with cystitis often, we need to do a medical history on her to see why she might be having repeat episodes of cystitis. Usually, cystitis can be prevented, so some of the things that we can do is to teach our patients some of the methods that can prevent them from getting cystitis. They should drink plenty of fluid, 1 to 3 liters a day. They should empty their bladder regularly, unlike us nurses who don't even go once a shift most of the time. We should empty our bladder regularly to keep our urine from becoming stasis. We should drink juices such as cranberry juice to help decrease the bacteria and also increase the acidity of the urine. We should take showers and not soak in bubble bath tubs with oils and such. And of course, I think I've been on the soapbox about, you should void after having sex, but you shouldn't be douching after sex. And a lot of women still continue with that practice because douching cleans out the vaginal secretions that are supposed to be protecting the meatus from certain bacterial functions coming in. Post-renal, pre-renal, and intrarenal. I just skipped those, didn't I? How awful. Know what they are. Know which ones. Pre-renal is if something happens that would affect the health of the kidney before it gets to the kidney, such as blood loss. Post-renal would be something like a kidney stone that is after the kidney that would cause urine to go back up into the kidney. And intrarenal would be something that affects inside the kidney, such as an infection. So if you had pre-renal azotema, remember what azotema is. It's that nitrogen balance uh, caused from your protein breakdown. Azotema, you want to be sure to know how we would reverse that. So if pre-renal is caused by something like blood loss, what would we do to reverse that? We would hydrate them. If it was caused from Dehydration, we would hydrate them. Any hypovolemia, any type of fluid loss, we would be, anything that's going to happen beforehand, we would need to be doing hydrating them. Post-renal would be like renal stones. Usually with post-renal, we would see, if we remove the renal stone, that we would be able to get rid of that. And then the intrarenal would be an infection like sepsis, and we could do antibiotics to take care of that. Now, acute renal failure, remember, acute renal failure can be reversed if we catch it in time. So, we want to be sure that we know what oliguric renal failure is. You had the oliguric, non-oliguric. You had the several different stages of acute renal failure. When they're in that oliguric phase, they have changes in their labs where the serum BUN, the creatinine, potassium, and metabolic acidosis are all going to increase, and you will have a lower level of urine output. So, because oliguric is low urine output, no matter how many diuretics you give them, they will not diurese. So, you want to be sure that um, you're doing those sort of things. Renal stones, be sure you know that you have the oxalate, you have the uric acid stones. So for oxalate, avoid your diets that are high in oxalate, such as organ meat. Be sure that you know that if it's uric acid, you would avoid fish like anchovies. For oxalate, it's organ meats like liver and kidneys. For oxalate, it's avoid eating chocolate, green leafy vegetables, nuts. But people who have uremic acid or uremic calcium, uh, they need to be sure that they drink plenty of fluid. Of course, anyone with stones should drink plenty of fluids, no matter what kind of stone it is. But they need to keep the acidity of their urine high by drinking their juices and avoiding the particular type of foods that they shouldn't have in their diet. Now, be sure you know that your creatinine clearance is very important in telling you what your renal reserve is. Usually we do a 24-hour urine to see what our renal reserve would be, because without the clearance, we don't know how drugs are going to affect them. And that, my dears, is the end of that. And I wish you good luck. And I know you can do this. And that is the end.